Hey, welcome everybody. I'm Dr. Dino Pappas with Rossi. This is the We Fix Pain podcast, and today we have a special guest, and we are in a special setting. We're in Charm with Dr. David Harris. Charm is the Center for Healing and Regenerative Medicine here in beautiful, scenic, and hot Austin, Texas, right? So we're here with Dr. Harris. One of the biggest requests we've gotten on this podcast is actually on the topic of regenerative medicine. There's a lot of myths. There's a lot of misconceptions. So we're here to clear up the science from the science fiction. So, Doc, tell us about yourself here. What's your background story? What's your origin story? How did you end up getting interested in regenerative medicine? And take us through. What's your path to be here today?
Well, thank you very much. It's great to be here, and I'm enjoying this podcast to give everybody some of our personal experiences and background on this subject of regenerative medicine. My specialty is physical medicine rehabilitation. So I went to medical school in Dallas at Southwestern Medical School, completed my residency in physical medicine rehab. Interestingly, back then, my field pretty much didn't have anything to do with procedures. It was all managing physical therapy, managing a rehab hospital, helping people get through their stroke or their brain injury or their spinal cord injury. So when I came to Austin, I was actually pretty much a spinal cord brain injury specialist. That's kind of what I did. And I was medical director of one of the hospitals here in town called St. David's. Over the years, I started doing more simple injections like basic steroid injections of joints, and I liked what I was seeing. And then I started doing more courses over a couple of years there in the early 90s, mid-90s. And pretty quickly became what's now called pain management, became an interventional pain specialist. And so I went from a field that didn't have much in the way of procedures to a field that actually had a lot of procedures, especially nowadays. So I went through the interventional spine treatments, and then ultimately that led fairly quickly into the regenerative world, which at that point the pain world was over here, the regenerative world was over here, and they did not meet in the middle. They sort of disagreed with each other.
Big disconnect.
Yeah. So the steroid guys and the blocking pain guys thought that the regenerative guys were kind of strange and voodoo and mystics, and the regenerative people tend to think that the pain guys over here were wasting a lot of people's time and money with steroids and maybe hurting them more than helping them. So they weren't really meeting. As far as I know, I was actually one of the first doctors, maybe the first, that actually started doing both types of procedures at the same time. So
you were a rare bird back then.
Back in 1995, for sure. I mean, I was using C-arms, X-ray machines to kind of guide my needles, which allowed me to be better at the regenerative model. But I was learning about recipes that were different than steroids, which has now led into this whole regenerative model. And so the regenerative model has now, I think, blended pretty well with interventional pain. And now, 25 years later, there's definitely this cohesion.
Synergy.
Yeah, more synergy. Still a little disconnected. But the pain doctors are now learning about regenerative. The regenerative guys are realizing that they need to have machines and X-ray guidance and ultrasound machines to kind of steer the way. And there's a more of a merging of the minds, I would say.
Yeah, I first heard about this trend of regenerative medicine as I was finishing chiropractic school, circa 2009. There was a gentleman up in Chicago where I'm from, and prolotherapy was it. And then it morphed into, I started hearing about PRP and stem cells, and we'll get into that in a little bit. But it's interesting. You had the foresight to, hey, I took this skill set, I need to morph and change it, and we can blend these two. Sounds like you were on the cutting edge back then.
Yeah, I mean, it was a neat field. It was kind of like riding the big wave, because I was kind of hearing both sides sort of arguments and agreeing with both sides rather than disagreeing with anybody. And the beauty of it is then you can take things to a certain level that may or may not be covered by insurance, or may not be covered standard treatment. But when you get to that edge of the box, you can get outside the box and go, well, I think I can repair that. So there's still a place for steroid injections. There's still a place where somebody might need pain management techniques. But then there's this whole new world where we can actually go, gosh, why don't we just cure the problem? It's this tendon, it's this ligament, it's this joint right here, or it's this constellation of 12 things. You can take the regenerative injections and treat them all.
Yeah. So a little bit more about yourself. I think people like to hear the origin story in the background. We kind of got the origin story. What does your practice here in Austin focus on? Is it athletes? Is it the 65-year-old that just wants to stay active? Is it the person that, Father Time is kind of kicking me in the butt a little bit, I need help? Who do you see here in Austin as part of your practice?
It's a good point. I think that we see Really, I've treated as young as 7-year-old. I've treated up to 100 years old plus. I'd say the sweet spot tends to be anywhere from about 30 to 70 in terms of people who want to continue to play tennis, play golf, enjoy their quality years, be active. And those are the folks that tend to do really well with regenerative injections. So they can be disc herniations, they can be nerve compression issues, knee injuries, shoulder issues. We can treat really all those. So we have the sports folks, we have the folks that are just trying to stay active as they get older. We also have our folks in the older populations that have degenerative joints, more arthritis, and we treat all that as well. So we can treat everybody from the meniscus tears in the sports population up to the meniscus degeneration in the older folk.
Yeah, it morphs in different age demographics.
Right, because the regenerative recipes work at all ages as long as the patient's healthy.
My favorite part of the interview, 5 random questions. No way of preparing for it. We're going to ask you some random stuff, put you on the spot, see what shakes on up. If you had to describe your personality by a flavor of ice cream, what would your personality be like? You've probably never been asked this question.
No, I have not.
Told you there's no way to prepare for this.
Maybe Rocky Road. I mean, I think there's a mixture of a lot of different things going on together, and there's a little bit of adventure built into it all.
All right, bucket list vacation. Your bucket list vacation is that you want to go to or thing you want to do?
I would love to take my family to Greece and to Croatia, Mediterranean, and enjoy showing all that. I've been to both places with my wife and my best friend in the years past, but I haven't had a chance to take my kids and my family to those areas.
Speaking to a Greek guy.
Oh, yeah.
Off the air, I can give you some tidbits. And I can even tell you how to swear with the right accent. All right. Question number 3 here. Beach home or mountain home? You got a vacation home. You got to pick one. You're going to the beach or you're going to the mountains?
Beach home.
All right. Somebody's buying you a drink at a bar. What are they buying you?
Old-fashioned.
Old-fashioned. All right. Last major question. Can't prepare for this one, so... Have you ever had a regenerative medicine procedure done on you for an ailment?
You would think I'm a zealot. In fact, I've probably had about 60 procedures.
Really?
I've had about 15 body parts that we have repaired since I was about 35.
Oh, wow.
I have a condition called Ehlers-Danlos syndrome where
you do?
hypermobility. So my ligaments, I'm a little stiffer than I used to be, but I used to be pretty wobbly. And so I've had a lot of different joint ligaments and tendons and joint strains. And so I've actually had a lot of treatment, all the way through the entire gamut that we'll be talking about. So all the way from dextrose prototherapy, some steroid injections, all the way up to stem cell procedures.
Interesting. Ehlers-Danlos is a tough one in our neck of the world because the biggest tools that we have typically involve some form of mobilization, tissue mobilization, joint manipulation. We do stability exercises, but when we're doing Ehlers-Danlos, you're light on any of the hands-on mobilizations, manipulations, heavy on the rehab. To be honest with you, I think there's a good synergy and fit between a guy like yourself, the prolos, the stem cells, and then some simple stability exercises.
Yeah, absolutely. In fact, as you say, a lot of what I do is to rebuild the stability back in the structure, and by the nature of Ehlers-Danlos and hypermobility, they don't have the structure.
Yeah.
So you can realign them many times, but they'll slip and slop back out. Our work will actually tighten the strength of the capsule, the ligaments, toughen the whole thing up, and get the socket to stay in place better. And when it didn't slop in and out, they don't need to be put back in.
Gotcha. So 30,000-foot overview. What is regenerative medicine? There's a lot of myths and misconceptions, and people think you just throw pixie dust out there and miraculously things get better. How do we define the field? How do we define the treatments? What is it?
I'd say, let me first divide the idea of regenerative medicine into what can be done in a lab, in a culture dish. Can you grow an ear? Can you grow an organ like a kidney? That falls into the same world of regenerative medicine, but it has virtually nothing to do with what I do.
Correct.
So you have this idea of, can we make the tissues grow and push them in directions? Can you make a stem cell become a nerve cell in a Petri dish? That's all very much research, experimental. We don't know where that's all going. It will probably be great as we develop those techniques. My world of regenerative medicine is the in vivo world, which is a patient comes to me with an elbow pain, a shoulder pain, a knee pain, or all the above, and we will take growth factors and selectively inject them into different parts of the structure to repair the ligaments, the tendons, stimulate the cartilage to grow. And so the pixie dust idea is almost true in the sense that it's hard to believe these growth factors can do all the things that they do. But the beauty is the body's designed to heal itself. And so when you plant those seeds where the defects are, the body will repair that. And that means the collagen can become tougher, stronger, tighter, thicker, more durable, which means your ligaments become tighter, stronger, better. Your tendon attachments that get beat up over the years can be repaired and the tendons become stronger. When you have an integrated system that has ligaments and a joint capsule working properly, the ball and socket works better, and then the cartilage doesn't get worn out. And then the patient's myofascial pain that is there superimposed on all this because the muscles are trying to hold things together. The muscles can go back to doing what they do as a mover and not have to be a stabilizer. So the key to it all is that structural integrity of all that collagen that's sloppy or torn or ripped, beat up, has holes in it. We repair all that stuff with growth factors, and that's really the essence of what I do all day long.
Yeah, and it's an integrated system. Usually when one structure is aggravated, irritated, inflamed, throwing a word there, something else can go awry, whether it's myofascial, whether it's ligament issue. Next thing you know is the premature wear and tear of the cartilage. We're an integrated unit rather than an isolated system. So who benefits? If we have to put a patient on the table, or guys like myself have to refer a case to you, is there a case where you say, that's the person I need for these types of services? How do we know who benefits?
Well, thankfully, I'm very familiar with what you guys do, and I love what y'all do. With high-quality physical therapy, high-quality chiropractic, manual therapies, y'all can achieve a lot of great things for people. When the structure seems to need that next level, it's weak, it's not staying in place, there's a clicking, popping, catching, that kind of thing, then those tend to become the patients that when they're not getting good enough results elsewhere, then that's what I succeed with. So I'd say the people who need me are the people who are sort of falling off the chart with other techniques. So I love getting referrals from chiropractors, physical therapists. You guys do such a great job at doing what your work does best, that when your work doesn't sort of hold things together, they probably need what I do.
Yeah, it's a good vetting process. Having a regenerative medicine expert like you guys, I happen to be a clinic 5 miles away, is nice. And it's nice because we can vet them and screen them, and so that when the patient ends up, you're like, I know what was done, I know what worked, I know what didn't work, and I know this person is the right patient for it. So it sets you guys up for success and vice versa. We send them to you and they come back. They've had proper management and the ball flows a lot smoother as patient care. What options are there? I looked at your website and it's a menu. And I've seen other websites in regenerative medicine, it's a menu. And I don't know on the menu who gets what, who needs what. So what options are there for regenerative medicine?
So there's the basic sort of misconception, but real, aspect of inflammation. People have inflammation, and they may have an inflamed tendon that we would call tendonitis, or they may have an enthesopathy, a structure where connection is damaged. Part of the game is trying to decide, is this an inflamed problem or is it a degenerative problem? And
by degenerative, is it, you're thinking like ischemic rather than inflammatory?
Ischemic perhaps, but I'm just thinking in terms of just the material itself being beat up.
Okay.
Like a rope that's gotten kind of frayed, or a rope that you maybe stick a pencil through that, you get a little crack in the rope. The rope still kind of holds together, but it doesn't work right. It's painful.
Gotcha.
So so basically, I may be off track for a moment, but I would say what we do is we treat that connective tissue, and we try to distinguish fairly quickly, is it inflamed? In which case, that person might actually benefit from an anti-inflammatory or steroid approach. Or if it's degenerative, then they're not going to really get much out of an anti-inflammatory, and they really need to go down a regenerative path. So I may do a steroid injection at first just to see if that calms things down. If the problem goes away, patient's happy, life is good. But if you do too many steroid injections, you're going to weaken or damage the tissue. So the trick is to try to figure out if the patient needs regenerative techniques. And if they do need regenerative techniques, then you move into the regenerative model. Now, that model involves several different recipes and different strategies. And part of it comes down to how bad is the damage? Do they need major tools to fix the problem, or is it a relatively minor problem? So that's a lot of our work is trying to sort out based upon a thorough physical examination. When I press and pull and push, and what's tender, where does the clicking, popping happen, what is the tendon snapping over something? So we spend a lot of time examining those structures. Then we look at the MRI scans and ultrasound studies and things like that to try to understand what's going on biomechanically. And once we sort that out, then we try to pick our recipes of various strengths to achieve a goal.
So number one in the algorithm, in your mind, classify. Your classification is degenerative or inflammatory. Inflammatory, the things that work well on patients, steroids, non-steroidals, injections, corticosteroid injection. Degenerative, going down the path of regenerative medicine for that purpose. Now, subcategorize the regenerative medicine. There are options out there. Platelet-rich plasma, stem cells, prolotherapy. Taking that step one step further. What's in that box?
Sure. So once you've established that somebody would be a good candidate for a regenerative approach, then you look at the recipes that are available. The standard recipes that are accepted now in America, that are used in America at this point, is the old standards called Dextrose prolotherapy, which is literally sugar. That's D-glucose. Dextrose has been used about 80 years to repair these things, and it's pretty successful. Like you mentioned the fellow in Chicago. Yeah. Dr. Hauser up there is a good friend of mine, good guy. He and I published some papers together, worked together. He was one of my early mentors that kind of got me educated quickly. So dextrose prolotherapy works really good. The problem with dextrose is it takes about 4 to 6 treatments to get most people better. You have to do it about once a month, so you're kind of seeing people for an extended period of time. It's kind of weak in the sense that if it's more than about a moderate problem, you're probably not going to make the patient that much better. So if they get a more severe tear, dextrose is a little bit of a weak way to do it.
Mostly ligaments with dextrose?
Ligaments, joint structures, joint capsule. I mean, dextrose has actually been proven to grow cartilage inside joints in a study that one of my students did down in Argentina.
Interesting.
So dextrose does a really good job of what it does, but it's kind of slow and it's only up to a certain point. But the beauty of it is it's cheap. It's available in a bottle. You can mix it up in 5 minutes. You can inject somebody in 10 minutes. They can be out the door. So it's a quick, simple way of getting people better. But they have to have a problem that's not too severe. And, it's good for a budget. If a patient has a little less money to spend, dextrose is a reasonable way to kind of help them get to the end result. What's also interesting is people like me, if you've got Ehlers-Danlos or hypermobility, you're going to have a dozen body parts that you may need work on. And dextrose allows you to kind of meet your budget pretty well and treat a bunch of things relatively cost effectively.
I remember shadowing. There was a lot of injections in multiple areas. Actually, the days that I shadowed, there was a couple hypermobility cases that were there. So, 30, 40, 50 different multiple areas. Yeah, and it was quick, 10, 15 minutes and out. So, what else is in that bucket?
So dextrose is kind of like what I would consider the lower tier. It works well, it's a good workhorse, but it's not your best tool. The medium level tool would be platelet-rich plasma. Most people know about that these days because that's kind of what all the athletes are doing nowadays. With platelet-rich plasma, you draw blood, you spin it down, and you get the concentrated platelets. Platelets in your bloodstream, we used to think of them as just the way your blood clots. You get a cut, you get a scab, but they do a lot more than that. When you activate platelets in an injury, a bruise or cut, the platelets actually release thousands of little proteins, and those proteins orchestrate this whole calling in of the brigade to heal the problem. So it brings in the white cells to fight infection, it brings in the cells to clean up the mess, to get rid of the damaged stuff, and then it brings in the fibroblasts to rebuild the fiber. So your collagen, all that tissue gets rebuilt.
Mobilizing the army.
Right. So the platelets orchestrate all that. So what we've discovered is if you draw blood, concentrate the platelets out of the blood, and you take those concentrated platelets and you pepper everywhere that you want the body to cause a reaction, you pull in the stem cells and the cells that do all the repair work, and the process repairs itself. It's the way your body has always healed. Whenever you've had an injury or bruise or cut, the release of platelets in that area is why your body healed itself. So we're just taking that very natural process that your body would normally do and focusing it on that elbow that really needs to be worked on, or that shoulder. Now the next tier above that in our practice is going to be where we use bone marrow concentrate. We call that BMAC, bone marrow aspirate concentrate. And BMAC is basically the stem cells and growth factors that we get out of your hip area. So we actually take. Good. This is the
Conveniently placed, Doc.
Isn't that nice?
Conveniently placed.
So here's your pelvis. We actually will aim our C-arm, our X-ray machine, at an angle like this, and I'll sterilize and numb the skin back here, and I put a small needle in here and I numb the bone. I put my bone marrow needle in here and I pass it inside that knob of a bone, and from there I can extract your bone marrow. It's fairly painless. I've had 3 of these done to me, and I'm actually going to have one in a couple of weeks to finish up my knee here pretty soon. And you just take it. It's really pretty close to painless, or a little pressure, a little ache. It takes about 2 to 3 minutes to actually draw the bone marrow. Real simple. No big drills, no big crazy machinery. I can literally take my needle and twist it in like a thumb screw with really no trauma. And then once it's done, you pull the needle out. So we take bone marrow from the hip bone, and in our practice, we will also take the blood and the platelets, because whenever I'm using stem cells, I also use platelets. So I kind of mix them both together.
Found that added benefit with this too? Okay.
Yeah, when we early on, we were trying one versus another, and we were seeing that the bone marrow seemed to work better at some times, and the platelets seemed to work better at other times. And we had trouble sorting it out. And about 10 years ago, I said, why are we doing both? Why don't we just do both? It's just as easy. And so we learned how to process both in our lab, and we learned how to do these techniques. Now all of my bone marrow stem cell patients are also getting platelets, and you kind of get the best of both worlds all mixed together.
Is one more of a rapid healing, and then one is more of like you fertilize the lawn so that it will heal with time, and then which is which? Mm-hmm. So one more, you 2, 3, 4, 5 days while this feels better, and then 2 months, that kicks in which is which? Yeah,
I'd say it's a lot of that, but it's a little bit more mixed together. Platelets, by their nature, are an immediate release recipe. So about 7 days to 10 days, the platelets have given their all, and that's what you're going to get as far as the reaction. Now, that reaction will stew along for 3 to 6 weeks or so after the platelet injection, but they kind of give their growth factors pretty immediately, within the week. Stem cells, on the other hand, have some neat advantages. They're like little growth factor factories. That's what they do when they're inside your hip bone, is they stimulate the other blood cells to pump out more blood. So they're like little foremen on the job site telling everybody, hey, get to work, get to work, get to work. When you take those stem cells out of there and you inject them into the same locations that you're trying to repair, now you're implanting little growth factor factories that, from the current evidence, live for at least 3 to 6 weeks, maybe 2 to 3 months, and keep churning out growth factors wherever you plant them. So the stem cells kind of have this long-acting effect where they continue to stimulate the healing process. So you kind of, when you mix it together, you get that short burst, and then you get that longer later effect, and that combination, I think, is why we see the combination work so well. Gotcha.
Did not know that. Let me ask you a couple things. If we are looking to explain this to a patient, like a patient in my practice, or you're in an airport and somebody's like, I think I'm going to do the stem cell thing, and you're like, I probably shouldn't answer this person's question. But you want to explain these types of therapies. Is there a good analogy or a good reference or something that you learned over the past 30 years of doing this where you said that explanation works? Like a real simple way of taking this complex and just kind of honing it down into a really good analogy, a reference, a joke, dad joke, whatever it may be on the topic. Because you're very educated on this. You've done this for a while. You live it, you breathe it, it works on you. How do we make this so that 1 or 2 sentences we're able to get this across?
Yeah, that elevator speech, right?
Yeah.
I mean, I think it's fairly simple when I just say we are taking your body's own ability to heal itself, packaging it up, and installing it right where we want the body to heal itself. I wish I could come up with a better joke than that. It basically is exactly that, and it sounds too good to be true. But then you do this like I do all year long for 25 years now, and it's exactly what does happen. We get about 85-90% of our patients are going to get dramatically better. Some people aren't going to get as good a result. There's virtually no side effects to it, so it's really easy to offer it. You're giving people their own blood back within an hour or so, or their bone marrow. So it's a simple technique, but the basics are we're taking what your body inherently would want to do for itself, which is to heal itself, and stimulating it to do it. And then if you need to, you stimulate it a second or a third or fourth time until you finally get the body to finish the
job. Treatment matching. And one of the things that we are all trying to figure out in medicine is we used to, years ago, before there was data and studies and all that, throw things up against the wall or at a patient and see if it sticks.
Mm-hmm.
How do we treat and match in this space of medicine? How do we match to feed you who needs the Prolo, or feed you who needs the PRP, or feed you who needs the stem cells? How do we match to get that miracle moment for that patient?
Yeah, it's a good question. There's a continuum, like we described a few minutes ago, of dextrose is for your kind of mild moderates, platelets would be for your kind of moderate to more severe, and then stem cells added in there for your even more severe cases. And that's a basic continuum. I'd say practically speaking, pragmatically, you talk about a shoulder, for instance.
Ball and socket.
Yeah.
Lots of motion.
Yeah, lots of motion, built to be kind of unstable, but it needs to be stable. So in that situation, if you've got labral tears, if you've got other large tears of various ligaments, like your inferior glenohumeral ligament, things like that, you're going to want to have the fancy recipe. So your stem cells mixed with platelets are going to be needed for those bigger bones. You got a big rotator cuff tear that's 1 centimeter or 2 pulled apart. You're going to need something to fill that gap that has some potency. So those you're going to want to use typically a mixture of bone marrow and PRP for those. If you just have a more routine problem like a rotator cuff tendon that's a little bit battered, a little beat up, maybe some small tears, that kind of problem, or an AC joint that's a little arthritic, those problems tend to do fine with platelet-rich plasma. So about half of my shoulders we would recommend bone marrow with the platelets because they have bigger tears. The more sort of standard baseball pitcher who hurts kind of problem probably can be handled, or a tennis player can be handled really with just PRP typically. Dextrose Prolo, again, I tend to use less these days just because it's just not as powerful.
Yeah.
A lot of my patients come in from around the country. If they're coming in and flying in here, they're not flying here for Dextrose Prolo therapy 6 times. They'd much rather come here twice and get hit full speed ahead.
Gotcha.
It's the same analogies talked about, say, with the knees. And that would be if you have a significant meniscus tear, or if you've got a dynamic meniscus extrusion where it pops in and out of the joint, which we see a lot. Those kinds of structures tend to do best if you use bone marrow with the platelets. Whereas if you have more of a routine achy knee, or a knee that has more of a S-anserine tendinopathy, or quadriceps or patellar tendinopathy, those tend to respond great to PRP. Okay.
Is there a case, you've had a very good, very long career in this, that hangs in the top of the mind where you say, I didn't know if that would quite work for that condition, but it did, and we had a happy outcome, a happy patient, and, it's something like, I probably should report it or record it, or something that's a case series?
Sure.
You weren't even sure that would be effective for?
Yeah, great question. I'm going to give you 2.
Awesome.
Okay. One of them was a case of somebody about 10 years ago from outside of Austin. He came to me with C1-2 joint arthritis, a lot of pain there. He was about 25 years old. He had had a car wreck. His X-rays from his chiropractor showed significant malrotation of his high upper cervical region. Pretty bad, and the guy was basically in a wheelchair. He couldn't stand up without his world going dizzy. Very bad equilibrium, a lot of pain behind his head and ear back here. And I had just started playing with those kinds of problems. I was among the first to work around C1-2 with this type of recipe. And I didn't use stem cells on him, I used platelets. And I thought, we should be able to help this problem. It was pretty clear. His x-ray showed significant abnormality. Long story short is we treated him once. He came back about 2 months later, and he was about 50% better. He was very, very happy. He's like, he could actually get up and walk out of his chair. His family was elated because he'd spent about 2 years, in bed. And so I treated him a second time. He came back about 6 months later and says, "Oh, good. How you doing?" He said, "I'm doing great, man. I'm 95% better." And I said, 95? This is great. So why are you here? It's like, I want to do it again. It's like, really? It's like, man, I'm on 100%. I can't believe what my life is like. And so I treated him a third time, and he's been great, basically symptom-free, pain-free ever since. The other one, this is a little more personal, and I won't use any names, but one of my sons fractured his L5 vertebra playing football and doing pole vaulting. And he had 3 fractures of his vertebrae. He had bilateral pars fractures, and he also had a pedicle fracture.
Oh, man.
And surgeons in our town all wanted to fuse him. Or just say, you'll never get over this, you're always going to have a slippage, you're going to have pars defects, spondylolysis, all that. And we were obviously accepting of that. And this was about 7 or 8 years ago now. So basically, my partner and I did a bone marrow PRP treatment twice on him, filled in all the defects, treated his facet joints, treated the iliolumbar ligaments, the whole lumbar system, but especially those fracture sites. Took him out of football, put him in a brace during the day, and put him on a bone stimulator type device, like they sell for spine fusions.
Perfusions.
Did all that for about 3 months, 2 treatments about 6 weeks apart. He's been pain-free ever since. We've MRI'd him, all of his fractures healed completely. His L5 vertebra is completely normal now.
It's stable too. When
yeah.
you flex him, you send him on weight bearing.
Absolutely, completely normal. So it was a great outcome. I still talk to some spine surgeons in town here who I know well, who completely will refuse to believe that we did what we did and that it worked.
Yeah.
So it's like, it did work. Here's the scan. You need more evidence than that.
Yeah.
So it's pretty funny to think that there's such a bias that this couldn't possibly work, that people still don't believe that. Another quick kind of case. This is a broad category of cases, but we've actually had 4 different people who were judged to be completely ACL torn deficient on their MRI scans, who after we treated them, they've had complete resolution of their ACL back to normal.
What was the time frame?
That we usually would treat them about twice, and we would rescan them. Rescan about 6 to 8 months later to see what they look like. And we've had the radiologist call us saying, I don't see any hardware. I don't see what happened. Where's the anchor? How do they repair this thing? So, well, we repaired it with needles and growth factors. And radiologists kind of look at us going, how is that possible?
Yeah.
But it's actually becoming quite possible. And so people who are being told they've got a complete ACL very likely can actually be repaired with injections now rather than surgery.
And I remember reading something not too long ago where there was a couple of orthopedic surgeons that were looking at regenerative medicine, but creating a scaffolding of which to stimulate that repair. Not only just the needles, but can we stimulate a device that will allow us to repair fully? And one of the orthopedic surgeons I talked to is if they nail that, that's the future of ACL procedures. So it's interesting.
Yeah,
you guys are on it a little bit quicker. You guys got to plan something now.
That's right. And before I sound like I'm totally crazy, how is it possible that these ACLs can float back together? First of all, I'm not even sure they're doing that. I think that what you have is a scaffold that's still there that the MRI scan just has trouble defining. So I think there's still bridges kind of holding things together, even though you see a big gap.
Do you think it's a magnet strength thing, or do you think it's the magnet's just not strong enough to perceive that, or do you think we're getting a shadow?
It's the resolution of the slices.
Okay.
Yeah. And so it looks like a full, and it probably is, it's still a full. It's as full as anybody else's complete ACL tear. But what I'm really getting to is a lot of the complete ACL tears are probably not complete ACL tears.
Yeah, they're 3/4, 90%.
Right.
There's something to hang that together.
Right.
You're just giving the body an environment to do what you do.
Right. And beyond the environment, besides just floating stuff in the fluid, when I've got those cases, we'll actually guide our needle and actually directly pepper the ACL at the top along the mid-substance and down to the bottom. So you can actually watch that under x-ray and tag the ACL along its entire length. Put little blobs, 4 or 5 blobs through that length of ACL. And that basically repairs it and stimulates it to become thicker and stronger.
Those are pretty cool cases, and the personal one's always good to hear. So, historical perspective, where did we start with this concept of regenerative medicine? Where are we now, and what direction are we headed? So, science and science fiction, where were we? Where are we? Where are we headed?
Well, where we were 80 years ago was some doctors that were pretty smart who figured out recipes that they could inject. What happened along the way is people discovered steroids. So in the 40s, 50s, 60s, they were using recipes. People were talking about this at AMA meetings about prolotherapy, and it got washed away by the excitement of steroids. In the 60s, when we discovered that you could just inject steroids and everybody felt wonderful, everybody dropped the idea of these other chemicals that were being injected. And then when I was a kid, everybody's shoulders were falling apart because they were all getting too many steroid injections, and people forgot to go back 20 years to what people were doing before that. So my generation of doctors in the 90s, we started going back and talking to the old guys who had gotten success and were still alive, and they taught us kind of how to do the regenerative model again. So steroids kind of was a kick in the teeth. It kind of messed it up for about 20 years, but then we've gotten back on board. When I got on board with Dextrose, again, I was getting a lot of people better, but I was still viewed as kind of a bit of a guru to some people, but certainly as a witch doctor by others.
Yeah.
And then platelets came along. When platelets came into my world in 2007, suddenly it was really easy to get people better. So you didn't have to fight the stigma of dextrose. You didn't have to try to convince somebody that sugar water was more than a placebo. I could say, look, it's platelets. Here's what's in platelets. We know this stuff does what it does. And so the platelets gave us this whole new world where suddenly everybody's getting better in 2 or 3 treatments. You made big differences quickly. And then stem cells followed about a year or 2 later, and we've added that in. So the history kind of has been sketchy or spotty because of the different moments of truth that have come along, of being disparaged and then suddenly making some sense when all the athletes started doing it. So that's kind of where we were, kind of where we've been the last decade. The future is super bright. I mean, I look forward to hopefully being around long enough to see what happens next. Because I've kind of gone through this witchcraft and voodoo phase to now being kind of on the crest of a wave that's really changing sports medicine all over the place.
Oh, yeah.
And giving us opportunities that keep people out of operations and stuff. Scaffolding and other recipes are certainly ahead of us. I think fractionating bone marrow concentrates and trying to figure out which layers you want or which layers you don't. Fractionating PRP is going to be happening. That's already happening now. Different ways of kind of separating out the different the inflammatory from the pro-inflammatory from the anti-inflammatory components. That's happening now. So I think there's going to be more of those evolutions.
And I think, too, some of the questions that I have and our patients have as well as dose response. I know that you guys don't do this, but there are a lot of folks out there that are selling regenerative medicine options, and what's being delivered is not what's being advertised. So making sure that the dose that the person thinks is getting injected into the patient and getting that proper stimulation of the body's natural system. I think dose response studies are kind of, in the future and hopefully going to make everybody's life a lot easier.
Right. I totally agree with you. I think that, we do platelet counts before and after, so I can calculate what my multiple of the recipe is that I'm injecting. We do that with bone marrow, we can do that with PRP. We have these numbers that we get to work with to try to catalog it. So we're trying to use that data to figure out what recipes work better for which problems. Do I need a 3 times concentration for something, but I need a 12 times concentration for something else?
Yeah.
If I'm injecting, like we inject discs now, that's one of the new things. I've been doing it about 8 years now. But if you inject disc tears like annular tears, we inject them with a combination of bone marrow and PRP, both of them highly concentrated, so I can get about 1 cc inside the disc without a lot of fuss and without distorting the disc too much. And so it doesn't have to be a big volume. We found we put too big a volume in, the disc got a little bit too angry and frustrated.
It's a pressurized system, and you're increasing the pressure in it, it's going to bounce back.
Right. So we found that if we highly concentrate our recipes and only use about a cc to a cc and a half, that we don't bloat the disc too much. And so those patients have been fabulous. And that was unheard of 10 years ago, the idea that we could actually treat a disc from the inside out. Now I do that every week with people. It's a routine to do 2 or 3 discs and just put stem cells and PRP inside the disc. There's studies right now that show bone marrow that works. There's studies that show that PRP works. We're among the few right now that just says, I don't know what's going to work better. Our experience has been that the 2 combined work better, and so we just put them both in there. But there aren't any good studies yet combining both of them, but that's going to be the future. And then when that happens, they're going to say, hey, that works better than either one alone.
Yeah, I've spoken to some physiatrists recently, and their ears are perking open because there have been so much, I don't want to say anecdotal evidence, but case studies, cases, colleagues in the physiatry world, pain management world, that their ears are perking up, that this is a solid option. And no longer is it voodoo, it's actually practice. And then collecting those outcome studies over time will kind of solve that. But it's interesting, you guys are ahead of the curve there. And a lot of my colleagues in pain management and physiatry are now more accepting of, we can't do steroids, it's not a surgical candidate. They're definitely not, facet injections or radiofrequency. Mm-hmm. Let's go after the discogenic mechanism there. So.
Right. I do want to make a comment. This is a bit of a segue, but it matches up. So what are stem cells and what are people calling stem cells? Well, stem cells in America are going to be bone marrow concentrate or maybe fat-derived stem cells. Those are both considered legit. The FDA has been a little questioning about fat, but they're pretty happy with bone marrow from everything we can tell. The kind of stem cells that people are being told are stem cells that are not stem cells would be some of the amnion, placenta, birth product types of things. And those, this year, the FDA came out pretty strong and basically said those are not legit. You can't use them anymore. They're not. They haven't been approved by the FDA. They need to get approved. They need to go through the proper drug licensing channels. So if you hear about stem cells and somebody maybe not getting better, but what they got was amnion and placenta, in reality, they didn't get stem cells. There's no living stem cells in any of those products. So they were being a little deceptive. Some would say very deceptive.
Yes.
The Federal Trade Commission now considers that fraud. So if anybody says, we're going to give you stem cells, and they're not using your own fat or your own bone marrow, you are not getting stem cells.
And I think Doc brings up an important point. That was actually going to be my next question is, does it anger you or agitate you when you hear the word stem cells? It can be a potpourri of who knows what you're getting. And I think you kind of answered that question there. So, Doc, I appreciate your time. I'm going to have you turn this over to you. Closing thoughts. For our audience, our listeners out there, providers like myself, average patients, what are your closing thoughts on the topic? What do people need to know? 2 or 3 highlights that you can kind of sum this down for us.
I think the big picture is this is for real. This is not witchcrafted voodoo. In the hands of a proper professional who has proper equipment, proper training, it can be done extremely safely. It can be done in ways that don't require you to be knocked out in a hospital. You don't have to be sedated for this. My patients are generally very wide awake while we do all these things. Maybe with a little laughing gas if they want that, or a little Xanax. But it's not torturous. It's not scary. It's very, very safe, assuming you're in the hands of somebody who understands good sterile technique. We're not growing tumors. We're not making weird things happen for people. It's very safe in our experience. So we're dealing with some of this safe. The insurance companies still consider investigational, unfortunately, so you're kind of left to pay for it on your own until they finally decide that it's acceptable or standard of care. But right now, it's still a little bit outside that box. The good news is those of us doing it, being willing to get outside that box, are actually really good at what we do. And so you're getting that. You're not getting a commoditized medicine yet. I think when insurance company starts paying for it, that worries me about the future, in the sense that then anybody who wants to make a buck can start doing it, and they're going to go to a weekend course, and they're going to say that they know how to do what I spent 25 years learning how to do. Now, I do teach all around the country. I've taught down in South America a number of times, so I'm actively trying to get the world educated about how to do it. But I think you do want to pick your provider properly, pick somebody who really has experience, somebody who knows their way around the block, somebody who's not just figuring it out on a weekend course last week. Yeah. But it's here for real. It's here to stay. Insurance companies will eventually start paying for it, but it could be 5 or 10 years. I love being in a field of practice where literally about 85 to 90% of my patients who I see every day are patting me on the back saying, man, my knee feels great. Can you work on my shoulder? My wife needs something. Can you fix my daughter? So that's all day long we're spending seeing people who are being referred by their friends and family because it just works. And because there's really such little negativity to it all. It's just there's a beautiful thing about getting your body to heal itself, and that's really what we're working with. And it can be done in very quick, simple techniques that actually work very effectively.
And it's nice. I've been able to, my hometown of Chicago, shadowing some clinics that did this, and it's great. You walk in, patients, generally speaking, are happy, they're productive afterwards, they're thanking the providers that I saw. It's a fun thing to see because people are starting to get their lives back, and it's probably fun, to have be a small part of their journey and kind of guide them along that path. Well, Doc, I want to thank you. I want to thank Charmed for hosting me today. I want to thank you for dropping all this knowledge on myself and our viewers and listeners to the podcast. Where can people find you? How can people get hold of you?
Well, we are here at Charm Austin, here in Austin, Texas, www.charmaustin.com. That website will take you through a lot of information that we put together so you can learn about it, phone numbers, contact points. You call our office. Feel free to come in and see us to get an evaluation. We evaluate everybody thoroughly before we treat anybody. spend an hour taking care of new patients, looking over all the data, trying to make sure that we understand the story and give you good advice. So we're here in Austin, but we do have a hotel next to us, and we have a lot of people.
It's a beautiful area in Austin, by the way. Very
yeah.
beautiful area.
Many people travel from all over the country, and even from Canada. Before COVID, we had people from all over the place. That's gotten a little bit less, but it's getting back to again. But it's if let's say I'm the best guy out there, maybe jokingly said, but there are a lot of good people. If you're in California, or if you're in Colorado, if you're in New York, just hear what we teach you and seek somebody who has similar experience where you are, and you'll be in good hands. If you're in our neighborhood, or if you choose to come here, we're here for you. We've got a largest center that's within probably 400 or 500 miles around here doing this type of work, and we've had a lot of years of cumulative experience getting good at this.
So come to Austin, see this man, eat some good barbecue, and hang out on our beautiful lakes and rivers. I'm Dr. Dino Pappas. This is Dr. David Harris. We are at Charm. I'd like to thank them. I will put in the show notes the demographic information for Dr. Harris's bio and the Charm information. This is the We Fix Pain podcast. We are signing out. Thanks, Doc.
Thank you.